Hi, I'm Heejoon.
And my name is Sarah Varghese, and our case study is of a 32-year-old man with olfactory hallucinations, weakness, and intermittent numbness. Olfactory hallucination is when a patient hallucinates and smells an odor that can be either pleasant or foul. That smell can be present at all times, or it can just come and go. So with our patient, he had recurrent 2-minute episodes of smelling sulfur-like odors. With that hallucination, it was associated with nausea. Additionally, the patient had intermittent numbness and tingling on his left upper and lower limbs. The patient had no alteration of consciousness, affect, behavior, memory, motor, or other sensory functions. He was found to have a lesion on his right temporal lobe. Therefore, he was transferred to Mass General Hospital in 2016 for further examination. The patient was both of African American and Caribbean ancestry, but he has never traveled to the Caribbean. He was born in the United States and lived in New York, where he worked in a law firm. There was no reports of alcohol or drug abuse involved, and he had indicated that he quit smoking 10 years before coming to Mass General. There was also no family history of autoimmune disease, malignant tumors, or migraine headaches.
According to his past medical history, he reported to have seizures and was receiving levetiracetam 500 milligrams before coming to Mass General. The patient also had ADHD and was getting dextroamphetamine to treat it. He was also known to have molar caries, which indicates that he had a spread of infection intracranially and that he had no known allergies. And just for his general examination, everything was resulted as normal.
So these are transverse images of the patient's MRI scans. So a transverse would be a horizontal cross-section. And when we look at this image right here, you can see that these would be the eyes, this would be the nasal cavity, this would be the right temporal lobe, this one would be the left temporal lobe, and in the center right here would be the brainstem. So where this arrow is pointing to right here, you can see there's this white region, which is the hypodense region, that's indicating the abnormality in the right temporal lobe. And when you move across these images, it's going up the brain. So looking lastly at this one, you can see that large region of the hypodense area. Again, these are more MRI scans. Here, this is the sagittal image, which is like a vertical cross-section. And this would be, again, the eye, the oral cavity. This line right here would be the tentorium cerebelli. This would be the right temporal lobe. And then again, this is a clear indication of that white area in the hypodense area. These two are the coronal images. This view, this would be the brainstem right here, the pons, right temporal lobe again with that white area, the hypodense region right here.
So this is the chest CT scan that the patient had because he was reported to have pneumonia. This is the frontal image and this is the axial image of his chest. This arrow is indicating that he had subtle right hilar lymphadenopathy, which basically indicates that he had swollen lymph nodes. If you see here, this is the rib cage. This here indicates the diaphragm. This is the heart overall, and pulmonary vessels, and then the hilum right there. So the clinical diagnosis for this patient was that he has a tumor in his right temporal lobe. It was believed to be a tumor in the temporal lobe because they can lead to the seizures, and then which also leads to the olfactory hallucinations this patient showed. It was reported that in 50% of patients with tumors, they can have seizures. The tumor itself, though, they didn't want to just they suspected that it might not be a tumor, so they wanted further analysis, and for further examination had to be done in order to see if it was sarcoidosis, which is a granulomatous disease, which causes swelling. In people with sarcoidosis, the immune cells basically cluster up together to form lumps called the granulomas. And then these granulomas may alter the normal structure and possibly the function of the affected organ.
So brain biopsy of the patient presented the non-caseating granulomas. It was concluded that a biopsy was necessary for a more accurate diagnosis. So when looking at panel A, which is right here, this shows focally confluent granulomas replacing the brain tissue. So you can see this area here and more over here. In panel B, it shows that necrosis is visible in the center of some granulomas, which you can see here. These are the dead tissues, the necrotic tissues, compared to this side. In panel C, as well as in panel D, it shows a small granuloma with a mild reactive gliosis, which are glial cells that are damaged in the central nervous system. And these are of the adjacent brain tissues. So it's a little bit hard to see here, but you can see here the gliosis there and there. And then also in panel D, it shows the granulomas containing abundant phagocytic cells in the connective tissue surrounded by dense lymphocytic infiltrate that spills out of the tissue. This can be shown right there.
So the final diagnosis for this patient was that he had neurosarcoidosis. And this is uncommon, but a potentially serious form of sarcoidosis. It mostly affects the brain, tissues of the brain, but it could also involve other parts, including the spinal cord, peripheral nerves, and then the muscles. It has also been found that patients with neurosarcoidosis, 85% of those patients are from African descent. And currently, there has been no identification to certain risk factors for specific to neurosarcoidosis. This form of sarcoidosis can also lead to symptoms such as seizures and weakness in muscles. For muscle involvement, it's more common in neurosarcoidosis than just systemic sarcoidosis.
Based on current research, the most effective treatment for neurosarcoidosis are immunosuppressive drugs. This may slow or stop progression, but it cannot actually cure the disease. Infliximab, combined with a low dose of methotrexate, was given as a TNF alpha inhibitor. This inhibits cytokine TNF alpha that causes tissue damage and can perpetuate the granulomatous process. 80 milligrams of prednisone was given daily to treat the inflammatory disease, and levetiracetam was increased to 1,000 milligrams twice a day for the increased seizure control.
So 17 days after his biopsy, the patient reported that he no longer had his olfactory hallucinations, but in place of that, he had more frequent episodes of numbness on his left side of the body. These episodes of numbness or tingling feeling would be, he said that there was approximately one or twice a day. And then he also reported to have continual hiccups that were not responsive to his medications of chlorpromazine, which he was administered 50 milligrams of. He also had signs of mood swings, acne on the shoulders, increased appetite with increased weight gain, along with persistent pneumonia. For these symptoms, the doctors decreased prednisone to 60 milligrams daily from 80 milligrams. And then he was also given gabapentin, which he was to take 200 milligrams of twice a day for his hiccups and pains. Trimethoprim sulfamethoxyl was also given as an antibiotic for his pneumonia. And they also added calcium and vitamin D to prevent bone loss.
So the patient now is in New York, 15 months after the procedure. He's there to work. And 3 months after the procedure, prednisone was replaced with methotrexate, and levetiracetam was replaced with lamotrigine. Also, this medication eventually got discontinued due to patient's preference 3 months after the procedure. The patient had not been using this medication for about a year. Both the prednisone and levetiracetam was discontinued due to mood changes. The patient reported that his olfactory hallucinations returned, although they were less frequent than before. He did not want to take any medications for this mild olfactory hallucination or sensations. And also it was recently reported that he had episodes of confusion, amnesia, biting of his tongue, and general seizures. At this point, the patient reported that he no longer had mood swings out, he no longer had irritability, numbness of his left side, and hiccups. The patient will now just be able to return to his law firm with his friend. So there was another repeat of the MRI scan, which revealed an enlargement of the lesion and a spread to the brain stem. This finding will most likely prompt an adjustment to his immunosuppressive regimen. This will probably be an introduction of infliximab, where they would double the doses and probably give the treatment every other day. These adjustments would hopefully prevent any side effects from occurring. But as of now, this is an ongoing case. Symptoms still need to be reported, and treatment needs to be continued.
That's it.
Thank you.
You mentioned the surgery. What surgery?
It was for the biopsy. They were indicating to the biopsy
Oh,
that
that
they
was
did, yeah.
Do they ever use radiation for treatment of this problem?
No, they did not. As of now, like, according to like research for neurosarcoidosis, it's more for the immunosuppressive drugs that have been known to be effective against it, but they didn't really use the radiation technique.
Can you talk about the triggers? What may have triggered an immune response? What kinds of things? If I was trying to figure it out in this guy, what would I be looking for?
There hasn't been any clear indication. Like the doctors themselves didn't really know what actually triggered it. He just because they were transferred from another hospital, and then it was already there, and then like I think it was a long persistent problem before he was actually checking in for that in the different hospitals, so they didn't quite know what actually triggered it.
What in your reading about this, did you come across a discussion of what kinds of things may have been? They didn't identify them here in this person, but what may have caused? Like what would I be looking for in the history if I was going to try to figure it out?
I think that was also the case in researches. They also weren't quite sure what actually triggers or because they said like there was no like actual known cause for these problems, and they're still like working out to figure what causes it.
That's why it kind of took a longer process, because they just noticed that he was having these sort of symptoms, but never really understood why. That's why they originally thought maybe it's some sort of tumor, but then they had to look more closely and see that it was a form of sarcoidosis.
Did his pneumonia resolve?
It hasn't been indicated that it ever resolves, so we're thinking like it's still kind of ongoing with it. Yeah, it's still.
But things were starting to progress and get a little better overall.
Yeah.
Was he ever on antibodies for the pneumonia?
Yes, he was.
Yeah.
What was that?
The trimethoprim sulfamethoxyl. Yeah, I think that was
made.
that was the medication he was getting.
What I was getting at in my comment was, I don't know about in this patient or even in neurosarcoidosis, certain films, but certain autoimmune disorders come about because a bacterial infection or a viral infection of some sort will trigger, you'll have some sort of cross-reactivity with antibodies that are self-reactive when your immune system is dealing with that infection. And that it's just something that I would wonder about as a curious person thinking about this. Is that, or is there a chemical exposure that happens that lead to this sort of thing? That's why I was also thinking about it. I don't know if chronic pneumonia is associated with neurosarcoidosis. Did they talk about that?
They haven't really gone into that. We also would have liked to see it. We were actually looking up stuff if it was related, but according to like this case, it wasn't really there. Yeah.
Anyone else? Okay. Well, thank you very much.